Welcome, everybody. We are going to give it one more minute and then we'll go ahead and get started. Waiting for everybody to pop on here. All right, why don't we go ahead and get started? Welcome, everyone. Thank you for being here today. Welcome to the 5th webinar in the State of Midwifery in California series. And today's webinar is about Black and Indigenous and Pacific Islander midwives in California and the importance of culturally concordant care and midwifery to address racism-based disparities. Off the bat, I just want to note that many of our panelists and facilitators and the folks who planned and organized this webinar are in the Los Angeles area or Los Angeles proper and are doing this work despite what is going on down there with this tragedy. And so just want to give big thanks and gratitude to you all for still showing up today and possibly attendees who are listening in who are also down in that area. That our thoughts and prayers are with you all, and just again a lot of gratitude, and maybe we can all give you some grace knowing that your heads may not be totally in the game in this moment. We can go to the next slide. So this webinar series is funded by the California Nurse Midwives Foundation. The foundation's mission is to enhance maternal health in California and address disparities in birth outcomes by advocating for universal access to the midwifery model of care, driven by a diverse midwifery workforce. The NMF has funded various initiatives that fall into 3 categories that you can see here on this slide. And today's webinar is part of their midwife aid and midwife advocacy arm, or what they aptly call MAMA. Additionally, their Bloom arm funds and provides support for vital community projects in order to ensure that local midwifery is available to those who need it most. And finally, their Seed arm directly funds midwifery student scholarships, particularly for BIPOC and LGBTQ+ students, as part of their commitment to diversify the midwifery workforce. And if you have been enjoying these webinars, you can donate at that QR code, because with more, we can do more. Next slide. Midwifery Access California is a large multi-stakeholder coalition that has been around since 2021. We have 60+ total partners now of midwifery practices, mental health plans, community advocacy organizations, state and local agencies, researchers, and more. And you can go to the next slide. And this is just a snapshot of the many coalition partners, community-based organizations, state and local agencies, and our health plans who are involved. And if you'd like to join us, you can go to midwiferyaccessca.org. Next slide. And in fact, that QR code there will take you to the website. A little bit about us. Our belief is that midwifery is a key strategy for improving reproductive healthcare access and outcomes in California. And our collective goal is to integrate midwife-led care into existing clinical practice settings and to amplify and expand community midwifery, which we'll be hearing a lot more about today. We are specifically focused on communities existing on the margins, with an initial focus on expanding midwife-led care in Medi-Cal. So this particular webinar was created in partnership with a couple of folks. First, I just want to give a shout out to the Around Birth Collective, who helped us market this initiative. And then a very big thank you to the California Coalition for Black Birth Justice, who was integral in creating this webinar. So I'm going to pass it back to Candace so she can talk more about the organization.
Thank you, Holly, and hi, everyone. My name is Candace Charles. I serve as the Research and Evaluation Manager for the California Coalition for Black Birth Justice, or how we like to call it, the Coalition for short, because it's a lot of words. The California Coalition for Black Birth Justice is a statewide organization that is committed to unifying and strengthening the Black birth justice movement in the state, and we do that in a number of different ways, one of which is through coalition building, as it says in the name. We have an illustrious group of strategic advisors that we've been working with to strategize what are some of the systems change efforts that we can enact as a group of advocates across the state to really move the needle on Black birth justice and Black birth equity and make that a reality here in California. We also are committed to caring for and building the capacity of the Black birth justice workforce. That means providers, but that also means folks that are researchers, social workers, etc. And then finally, one of the hallmarks of our work is scaling systems change improvement through our work with healthcare institutions. And what that looks like in practice is working with hospitals, doing technical assistance around quality improvement work as it pertains to Black birth equity. And so we are so excited to be co-hosting this event with MACa, and even more excited for our panelists who you'll hear from later, as well as our lovely facilitator. So very brief introduction because I want us to get into the meat of things. But before we do that, I'm going to pass the mic to my colleague, Asaya Harville, who will give us some grounding around what we're talking about today.
Thank you, Candace. Hi, everyone. As Candace mentioned, my name is Asaya Harville, and I serve as the Associate Director for Clinical Strategies and Engagement with the Coalition. And so as a way to kind of frame our conversation today and for purposes of having a shared definition, I wanted to give you all a little bit of background, and then we'll get into the panel. So first, we wanted to provide a shared definition and framing of birthing justice. So when you hear us talking about birthing justice for today, this is sort of the definition that we're going off of. And Black Women Birthing Justice actually defines it as a part of a wider movement against reproductive oppression. It aims to dismantle inequalities of race, class, gender, and sexuality that lead to negative birth experiences, especially for women of color, low-income women, survivors of violence, immigrant women, queer and trans folks, and women in the global South. Working for birth justice involves educating the community and challenging abuses by medical personnel and overuse of medical interventions. It also involves advocating for universal access to culturally appropriate, women-centered healthcare. It includes the right to choose whether or not to carry a pregnancy, to choose when, where, how, and with whom to birth, including access to traditional and Indigenous birth workers, such as midwives and doulas, and the right to breastfeeding support. We can go to the next slide. In addition to that, we thought it would be helpful to provide a shared understanding or definition of what we are framing culturally concordant or culturally congruent care as a part of this webinar. So the way we are defining it for today is that providers are representative of diverse cultures, lived experiences, and backgrounds. Cultural concordance goes beyond cultural competence and humility in that it is not simply about respecting, understanding, or being open to another lived experience, but actually sharing it or aspects within it that can allow for a deeper level of discernment and or understanding. Cultural congruence can also be compatibility that exists between a provider and a patient or client. We can go to the next slide. And finally, before we get to the reason why you all are here, which is to hear from our panelists and from our wonderful facilitator for the day, I wanted to provide a very brief history, very brief, of midwifery in the United States. I'm not going to read through the numbers and dates on this slide, but I do want to share the following information. Midwifery has been practiced by Indigenous people native to North America for generations, well before the colonization of this country. Midwifery was also practiced and still is practiced globally before the formalized education requirements that colonization created. In addition, midwifery practices were brought to the United States by people of African descent who were stolen from their land and brought here. They were trained through apprenticeships by generations of experienced family members or peers, and these midwives provided safe and affordable care to pregnant people in their communities. For many years, the practice of medicine did not encompass the work of reproductive health care. However, in the early 1800s, the medical field of obstetrics began to develop, and white male physicians often recognized midwives as competition, thinking about them as an impingement on profit and stature. I'll let you read this timeline, but I wanted to note that there is a glaring reason for the disparity in representation for midwifery that we see today, and it's a result of the intentional anti-midwife campaigns that played on racist and xenophobic tropes that painted foreign-born and Black midwives as illiterate, careless, lazy, incompetent, unclean, and dangerous. The Shepherd-Towner Act of 1921, which was a federally funded statute intended to support and improve outcomes for infants and birthing people, and required states to regulate their midwifery workforces. This statute actually funded white male obstetricians and white female public health nurses to quote unquote educate community midwives in normal birth and to act as gatekeepers to determine which community midwives were actually deemed as appropriate care providers. The American Association of Nurse Midwives, founded by an active white supremacist, did not allow membership of African American midwives, nor were Black nurses allowed to be educated at the Frontier Graduate School of Midwifery from 1939 until the founder's death in 1965, despite being in direct violation of Brown versus the Board of Education from 1954 and on. This organization became part of the newly created American College of Nurse Midwives, which we know is still in existence today. This information and more is adapted from the sources that are listed on this slide, specifically from the first one called Quickening, which is the official digital news site of the American College of Nurse Midwives, and was so eloquently stated and written in there by midwife Michelle Drew, who is the chair of ACNM's Black Midwives Caucus. I encourage you all to read more at those sources as they have additional references and opportunities for learning. We can go to the next slide. Within the last decade, historical and contemporary accounts of midwives, along with the efficacy of the midwives' model of care for pregnancy, childbirth, and general women's health, have become increasingly popular in mainstream publications and documentaries. Yet very few of these accounts actually represent historical or contemporary Black midwives and midwives of color more generally. Despite a long history of midwifery within these communities, Black women specifically represent less than 2% of the nation's reported 15,000 midwives. Despite a revival of midwifery during the 1960s and 70s, only 1% of today's births in the United States are actually attended by midwives, and Black midwives and Black mothers are only a fraction of that 1%. In Keisha Good's dissertation here, Birthing Blackness and the Body, Black Midwives and Experiential Continuities of Institutional Racism, her qualitative study actually talks about how there's a very racist and classist denigration of Black midwives from the early 20th century that is still manifesting itself in the experiences and perceptions of predominantly white midwifery education programs and professional organizations. These experiences of institutionalized racism and negative and controlling images of Blackness were framed as the quote unquote contemporary midwife problem. We encourage you to continue learning about the history of midwifery in the United States And I want to shout out a couple of ancestor midwives who many of you may have heard of, but you may not have. And that is Mary Cooley, Ani Lee Logan, Margaret Charles Smith, Biddy Mason, and Gladys Nichols Milton. These midwives and the legions of their unnamed counterparts are directly responsible for helping to establish and sustain the science and art of midwifery here in the United States. We also recognize and acknowledge that the spirits of all midwifery ancestors, many of whose names we may never know, upheld the highest standards of care and birthing justice, even in the face of adversity, discrimination, and racism. And they ensured the safe arrival of generations, many of them having never lost a baby or a mother or birthing person in the process. Next slide, please. And now to the good part. I have the distinct honor of introducing today's panel moderator, who might know a thing or two about some of the names I just listed. And so I will read her bio and then I will pass it over to her. Linda Janet Holmes is an internationally recognized author and former director of the New Jersey Office of Minority and Multicultural Health, and has spent more than 5 decades recording oral histories and writing about historic Black midwifery practices. Her most recent book, Safe in a Midwife's Hands: Birthing Traditions from Africa to the American South, focuses on the practices of Black midwives whose holistic approaches are essential counterbalances to a medical system that routinely fails Black mothers and babies. Months before Safe in a Midwife's Hands arrived in bookstores, Miss Magazine named Holmes's book the most anticipated feminist book of the year. The Congressional Black Caucus recognized Holmes' previous book, co-authored with Margaret Charles Smith, called Listen to Me Good: The Life Story of an Alabama Midwife, for documenting the work of a life-saving midwife. 20 years ago, Holmes curated Reclaiming Midwives: Stills from All My Babies, a traveling exhibition housed at the Anacostia Museum and Center for African American History and Culture, Smithsonian Institution in Washington, D.C. Other books by Holmes include A Joyous Result, Toni Cade Bambara, writer and activist, and she co-authored with Cheryl Wall, Savoring the Salt: The Legacy of Toni Cade Bambara. And with that, I will pass it over to Miss Linda Janet Holmes.
Thank you. I'm assuming that I am positioned so that everyone can hear me and see me at this point. I wish I could see you, those of you who are gathering, that, like the old school way, like we'd be in the same space and feeling each other's energy, which would be wonderful. I'm actually in Virginia now. But let me just dive in, because I know we're going to be watching the time, and my goodness, I am, sometimes I have an hour to talk about this and people have to say, time's up, time's up, time's up. So let me just dive in. I think the most important thing to know about my work is that it comes from my own personal birthing experience, which my daughter, I think, will be close to 50 years old. Her birthday, I think, will be in March. So 50 years ago, I gave birth to my daughter at St. Joseph's Hospital in Paterson. But prior to giving birth, I'd been very much involved in the Black student movement, the revolutionary movement, following the assassination of Dr. Martin Luther King. And we came up with our list of demands. We were involved in demonstrations, and we were involved with taking over white spaces and making certain that our books by authors by Black folks, that Black students, the number of Black students increased. And it was that fire and that energy that also brought to campus people like Toni Cade Bambara, Nikki Giovanni, who interestingly were both single moms and pregnant at the time that I met them, and shared their birthing experiences with me when I was 21, 22 years old. So when I decided to give birth, an opportunity for a midwife simply did not exist. I did take classes with Elizabeth Bing, and the class was made up of, essentially all white middle class Upper East Side women and men, all married. And the class was designed to empower them to be able to walk into a birthing space and to have the birthing experience that they wanted and that they chose. And so I, with the, the fire of the Black student movement, the Elizabethan class, entered the birthing space at St. Joseph's Hospital, expecting to be able to, I mean, the hallmarks, being active in labor, having your partner with you. And anyway, there was a red light practically for all of the issues and all of the concerns that I wanted to have supported at the time of birth. In retrospect, that experience and my experience as a activist in the 60s, that what felt like a nightmare at the time was actually my call. I will talk a little bit more about midwives having a call to practice, was my call to action, which has actually lasted for the past 50 years. And it also led to my decision to seek a position as an administrator, as an activist with a nurse midwife program at the medical school in New Jersey. So we're in the 1970s. What I learned is that the history, as was just mentioned, of midwifery in America focused totally on the history of nurse midwives, overwhelmingly white nurse midwives at the time, and completely demeaned or walked over or did not include the history of Indigenous midwives, African American midwives, or immigrant midwives. UMDNJ, the University of Medicine and Dentistry of New Jersey, is located in Newark, New Jersey. And there was, in the 1920s, an immigrant community. And among those, in that community, there were many immigrant midwives. And it just so happened that I came across an article in the Journal of Public Health indicating that those midwives actually had better outcomes than doctors at the time. When I attempted to negotiate bringing into the seminars and the workshops that I was doing with nurse midwives in that educational program to include information about immigrant midwives, Indigenous midwives, African American, traditional midwives, grand midwives, as we often refer to midwives from that era today, I was told that the American College of Nurse Midwives only focuses on the history of nurse midwives, i.e., a predominantly white profession at that time. And then, and to some extent still now, and then I was told that Black traditional midwives, Indigenous midwives were definitely not to be included. And I should share with you, and this is not in the book, I talked about some of the other stories that I just mentioned, but I did not say in the book that it was my decision at the time to actually leave my job there as an administrator and as teaching some of the seminars because of the refusal of the American College of Nurse Midwives to permit any recognition of other than nurse midwifery history. When I had an opportunity to speak I was invited by Judy Lidoff to join, who wrote a wonderful book on the history of midwifery, to join her at an American College of Nurse Midwifery conference to talk about midwives and midwifery history at that conference. And I was told that only nurse midwifery history could be discussed at an American College of Nurse Midwife conference. So that put a fire in me. I was talking about the fire from the student movement. That also put a fire in me. And the fire that ignited was that I had a call. The call was to do whatever I could to document some of that history that was missing from the literature, not just only the midwifery literature, but the literature. And I received a fellowship from the National Endowment for the Humanities that provided some support for me for my daughter and I, to move to Alabama for 6 months and record the oral histories of more than 50 traditional African-American midwives. It was, and it remains, one of the hallmarks, the highlights, the most significant moments of my life, because I learned from them that, one, that their outcomes had not been a part of any of the discussions around the recent law that had been passed in Alabama, which eliminated the practices of the traditional midwives in 1978. And I was there in Alabama in 1981. So they were no longer in practice. In the process of eliminating those practices, there was no recognition of outcomes. There was no recognition of their role in the communities, their extended care. So I was able to capture from them, in their own voices, from their own perspective, their traditions and some of the cultural aspects, as well as some of their recognition and celebration from Blacks in the community. One of the expressions that I became familiar with when I said, "Do you know about midwives in Alabama?" They would say, "Midwives got us here." Practically everyone born here, who Black folks as well as some white folks, but Black folks were attended by midwives, by Black midwives. And the reason that midwives were being eliminated was because in 1978, the civil rights laws were forcing the state of Alabama to open up hospitals and integrate them. Let me just briefly talk a little bit about what I learned from talking to midwives. One, call to practice that was mentioned a little bit earlier. It wasn't a job, it wasn't a career. Midwives said if they didn't respond to the call, they would be, their life would be out of balance. They would feel that they were not doing what they were supposed to be doing. Many of these midwives were also lineage midwives. They were midwives who had inherited they use that word, inherited their practices from their mother, from their grandmothers, from great-grandmothers, who also had practiced as midwives. And Margaret Charles Smith, who the book was mentioned, she, listen to me good, she, her grandmother, she was in her 90s when I interviewed her. Her grandmother was born in Africa. And it was her grandmother who walked with her into the neighboring woods and taught her about the plants, the bark, and how to make teas. So this is, it seems like a long time ago, but this is very, very recent history, in a sense. So from the beginning being the transatlantic slave trade 400 years ago, to the time that the midwives were eliminated in Alabama and across the Deep South, the overwhelming majority of folks were attended at birth by Black women who were midwives. And only when federal government forced opening up hospitals did that change. So as I said, one of the traditions that midwives followed was this idea of midwifery as a call. Another idea was that the midwifery space was a space for expressions of spirituality, such as music, song, and prayer. But it was also a space where many of the practices that midwives continue today or in the room now, and have since been documented by the leading medical journals, were among the practices of these midwives. One was, all of the pharmaceutical medical access to drugs was not possible. So it was herbs, it was plants. It was skills in massage. being able to use massage to identify the position of the baby in terms of the time of birth. It was using alternative birthing positions, which the health departments that regulate the midwives told them, you've got to get the mothers in the bed. But the midwives insisted and resisted those commandments. Also, there was the cultural components, which led to my second book, Safe in a Midwife's Hands, that were being dismissed as backwards and stereotypic, included traditions such as birth being a woman-centered space. It included traditions such as, I mentioned the alternative birthing positions. It included traditions such as burial of the afterbirth following the birth. It included such traditions as a taking up ceremony where the midwife would come back, similar to naming ceremonies on the continent, and be involved 7 days later in holding up that tradition. And I just got the 2 minutes warning. So I will move in the last 2 minutes to my second book, because my second book was my second kind of calling, because I knew when I heard about these traditions that was passed on to them by their grandmothers, some of them enslaved and had, actually survived the Middle Passage, that what was being called superstitious and backwards and lacking scientific wisdom were actually expressions of African culture that had survived the tumultuous events that enslavement incurred. So these women of African descent, these Black women held on, like, we talk about the music, we talk about the food, we talk about dance, we talk about language, but these Black women savored these traditions, held on to these traditions, and passed them on so that I could go to Africa, Ghana, Ethiopia, and Kenya, and meet midwives who described very similar practices in their culture, including naming ceremonies, including burial of the afterbirth, and those practices like alternative birthing positions, so that these traditions that have been passed on to them by their grandmothers can actually be traced back to the ancestral wisdom found on the continent of Africa. And I have to say that for me, that experience of being greeted by Black women in Africa who were midwives, when I told them that I was bringing to them the stories of midwives who had continued the traditions of their ancestors born in Africa, that is when the tears came, the crying came, and the joy came, that in spite of all that has happened, even recently, to denigrate, to talk about the quality of care, all of that, we as Black women, and also we're also now recognizing that Indigenous women, women of Latino descent, are also beginning to do research, and I'm learning this by doing talks, to understand that these practices are to be savored, to be continued, and to be celebrated. And with that, I think we can begin to move into the panel for our discussion. And I think, let me just ask if anyone has the name of, Biddy Mason was mentioned, and any names of traditional midwives who are in their family, who we can celebrate now, please put those names into the chat. The time is now for that recognition. So let me take a deep breath. It is very, I just, every time I give this talk, it's hard for me to kind of shift gears, because it is it brings back the power and the strength of these traditions. So I'm going to ask for each of the members of the panel to tell us their names. And I just talked about this, the idea of the call, but to also tell us why you became a midwife and just a little bit about the beginning of that journey. So I don't know if there's any order for how the midwives want to respond, but you're welcome to begin.
I'll go. I'll jump in. First, I just want to say my name is Kiki Jordan. I'm a community midwife. I'm a certified professional midwife and a licensed midwife. And I want to say that I feel honored to be in space with Linda Holmes because I started my midwifery journey about 20 years ago, and I read Listen to Me Good as a midwifery student, and it's just really special to be able to share space with you on a panel at this point. Thank you for the work that you do and for capturing and protecting the legacy of Black midwifery. And listening to you remind my midwifery journey, you know, I have a lot of Black midwife friends who have stories about a family member who was a midwife, a great aunt or a great grandma who was a midwife. And I don't have that. I really come from the destruction of midwifery and Black midwifery. I'm an African-American woman who was really committed to Black liberation, Black psychological liberation as a very young woman. And that kind of led me similarly to my journey to choose home birth for the birth of my own son. And I had my son when I was a young woman, and all of the women in my family had had surgical births prior, and those were the stories that I was hearing, and I was kind of being told to just expect that. And so my choice was, I think, from a place of resistance. And then my choice to become what I like to call myself a community midwife, which means I trained and practiced in out-of-hospital settings only. I also think that was a statement about resistance and another commitment to a type of liberation, like the liberation of our bodies, our beliefs in our bodies, that story that birth is a medical emergency. I just wanted to be a part of breaking free from that for myself and for my community. I have a practice in Oakland called Birthland Midwifery. We are a community of folks working hard to bring an independent birth center to the city of Oakland. I am the NACPM board president. I'm a mama. And I'm a sister midwife, and I'm grateful to be here. Thank you.
Okay. Who would like to share just briefly their story?
I can
I'm
jump
not
in.
seeing all the names on the screen, so I can't. Hi, Lisa.
Hello, everyone.
Yes.
Yeah, what an honor. What an honor to listen, to re-meet people and hear you reintroduce yourself, Kiki, and just to be in the space. Magandang hapon sa inyong lahat. My name is Jhoanna Galvez. My pronouns are she, they, sha. I am a licensed midwife. I'm an IBCLC. I'm based out of Long Beach. I'm the founder of a private practice called Malaya Midwifery. And I'm the co-founder of the Wellbeing Alliance with my partner, Debbie Allen. And through that, we offer free prenatal, lactation, mental health, and postpartum care in LA. I am Asian. I'm an LA native. I'm from an immigrant Filipino community. I'm part of the LGBTQ+ community. And I'm here from all the work of the Black, Indigenous, and POC midwives have come before me. So I am really honored to be here. Currently, I am in LA participating in mutual aid for families impacted by the fires. So if you want to connect, feel free to reach out. And then Midwife Marina has started Life Brigade, and it's a LA relief effort to support groups for BIPOC midwives and doulas responding to the fire. And it's guided by the midwives who responded to Lahaina. So I'm here. And my call to midwifery came from being in social justice and art and not really wanting to have a baby at all. And being more on the pro-choice side, abortion access side. And my cousin asked me to be her doula, which I had no idea what that was. And so I flew to Canada and she had a baby in Montreal. So my first actual introduction to midwifery was socialized healthcare and 1 year of maternity leave, and postpartum doulas is part of your care. And then I came back home and said, what was happening? And I really didn't know about what was happening within the Black community. I didn't even know like why my family had so many surgical births. So that birth opened my eyes and I had to ask some questions, unravel some stories. And when Linda asked about like who are our ancestors in that journey, I learned that I didn't even know that my grandmother had all her babies at home, except for one. And of course, and then that midwife was named Kamoneng, and Kamoneng would address everyone in that province, and sometimes she couldn't. So then my grandfather was the delivering provider. And it brought in like more questions about how we show up when needed, how all people can be midwives. So that was my initial call in, and that was 15 years ago, and I'm still learning. And yeah, that's a little bit about me.
Thank you. And thank you for, midwives and doulas don't put themselves in boxes when they think about their care and their work and their calls. So thanks for all you're doing to support families and moms and babies in the crisis that's occurring now in LA. And also thanks for mentioning, I've been talking about Indigenous midwives, Black midwives, but I was just reaching back to see if I could pull the book off of my shelf, but there's an excellent book on the traditions of Japanese midwives in California, and I will maybe put that in the chat. And then also a very good friend of mine, Debbie Lee, was sharing with me about her grandmother who, out of the Chinese community in California, had continued those traditions. And so there's still a lot of work to be done just in documenting the history of the significance of midwifery practices. I think there's, I don't see all of the panelists on my screen, so I'm not able to know who will be speaking next, but I know that there's 4, so that whoever would like to talk next about their call to midwifery.
I can go next. Hi, everyone. My name is Jyesha Wren, and I am a certified nurse midwife. I practice in Oakland, California, and I am part of a team who founded Beloved Birth Black Centering, and that is a bias for us group perinatal care program providing midwifery-led comprehensive whole person group perinatal care. I serve as program director, and I'm also now on the journey of founding Beloved Birth Collective so that we can grow this movement. And a little bit about me, I don't know if I have any relatives in my ancestry that were midwives, but my journey really came from, I'll start at the beginning with my birth story. I was born at home in New Orleans. My mother is a white woman. My father was a Black man, so I am a Black, a mixed race woman. And she had an immigrant white woman midwife in New Orleans. And she received care that she felt so good about. And my whole upbringing from when I was young, she was a hippie lady who believed in really educating me young about all the things to do with, the social movements of the 60s and the 70s, feminism and back to the land and more natural healthcare. And that included the way that we birth. And so I grew up with this birth story of hearing that, the midwife would come check on her at home and she felt really supported and everything was smooth. And the midwife just brought some olive oil when her contractions started and slathered her up and out I slid and everything was good. And so I really grew up with this story and just kind of was like, okay. And so my early imprinting about what birth was all about was that, it was a natural physiological process. And I gathered from that story that midwives were the experts in supporting and facilitating that natural process. and that it could be a joyous and satisfying and empowering process. My mother always told that story with, a big smile and satisfaction. And so I grew up though, and didn't think I was going to go into healthcare. Never planned to be a midwife. I grew up, again, she was a white woman, and she had moved me to Northern California, a very small rural town in Humboldt County, and it was a very racist town. And so I grew up very passionate about anti-racism work in general, about racial justice work. And so I was studying sociology and thought I was just going to go that route. I didn't have any plans to go into healthcare until I discovered our crisis in preventable morbidity and mortality, our racism-based disparities in this country. And that was really the moment for me. And when I realized that, my mother never told me that part of the story. As a white woman, she I don't think was able to share that part with me and understood what was going on and how my birthing journey might be really different than hers. And, what were the chances that I would be able to access the kind of supportive care that she was able to access? And so that just sent me down a whole path. And that was the call moment for me of like, I can't do anything else in this world with my life, but try to fix this problem. And so I then became a midwife. And at the end of my training, I got pregnant. And so I'm also a mama. And I had the great fortune of having Kiki actually help me birth my son at home. And so that was a beautiful, beautiful experience, and I'm very thankful for. And from since then, for the last 8 years, I've been practicing in Oakland, a little bit with Kaiser in Redwood City, but primarily at Alameda Health System in Oakland. So so happy to be here with you all. It's a huge honor just to be in this space with Linda, with all these wonderful panelists and wonderful policy activists helping us to create more access to midwives and to keep this tradition alive. So thank you.
So one of the wonderful things about these spaces is that we realize that we need like hours, right? A day. We could spend, we could do a whole workshop, right, for a week, just kind of taking these ideas and these themes. But since we have some time constraint, I thought maybe we could maybe shift to talk a little bit about, because you did such a wonderful job of just describing your cultural identity and how it relates to midwifery. But how does that cultural identity intersect with your midwifery practice now? And maybe give us like a short story, an example about when racial concordance mattered in caring for a patient or a woman that you were serving at that time. And again, whoever is comfortable responding first can do so, and we'll just make it a round table. Is it Kiki coming to the forefront?
Well, I was going to ask Janelle to introduce herself. I love your background, and I'd love to hear more about you.
Thank you.
Janelle, let me just say that I am not seeing all of the, and I will ask for the tech people to help me a little bit with this because I'm not seeing all of you. Now I'm seeing all of you, but Janelle, I apologize because I wasn't seeing your beautiful image on the screen. So please, why becoming a midwife is very important for us all to hear.
Thank you. Thank you so much. Like I really appreciate that. And I totally understand with our Zoom technology, even though we've had it for a few years, it's really easy to get confuddled with what changes. And if you have open screens, it can really be confusing. So no worries. So I'm honored to be here. It's a pleasure. And thank you. I'm Janelle Palacios. I'm CEO and founder of Encoded for Story, where I offer consulting services to national and state entities such as perinatal quality collaboratives and maternal and infant mortality review committees on American Indian, Alaskan Native perinatal health and data. I'm also a nurse midwife working in the Kaiser system in Oakland. I've been a nurse midwife for 16 years, but I've been doing women's health for nearly 30 years because I count my childhood as part of that time. My journey started when I was a kid. I grew up on my homelands on the Flathead Indian Reservation in Montana, home to the Confederated Salish and Kootenai tribes. And in my community, it's not uncommon for young people to become parents early in life. And I myself come from at least 3 generations of young mothers. A number of young Native women I grew up with became pregnant early in life, including a dear friend. And if anyone knows anything about American Indian health, our ancestors gave up basically what we know as the United States in exchange for certain access to resources, and healthcare is one of those resources. So we have Indian Health Service, serves a number of tribal people. I grew up in this system. I was assigned an Indian Health Service physician, and like my dear friends who were pregnant, we had one Indian Health Service physician serving on a reservation, and this person was a horrific provider. And I knew as a teenager that I wanted to do something for the women and family and friends in my community so they would not have to experience atrocious care. I decided that becoming a nurse was in with reach. And as I learned about nursing, I then began learning about nurse midwifery. I graduated from nursing school and immediately entered graduate school in California. And I pursued a master's and PhD simultaneously. It was the work I did on I was trying to help researchers and healthcare providers understand that history is really important to understand Native outcomes. And I put together Weathering from Arlene Geronimus with historical trauma about 25 years ago to help people understand that the intersection of those two things help explain why Native American maternal and infant outcomes are abysmal. But many people would not really know that because our numbers are not reported. So that's another issue, is that we are erased in a lot of the national and state data, and we're not counted correctly. So we're made invisible. But if you were to look at some of the more newer reports, you would find that Native women die anywhere from 2 to 7 times the rate of white women in our country related to maternal death. And our infants die. Sometimes they swap in place with Black infants for first place at the highest rates in our country. While I do practice clinically in the Bay Area, my service to Indigenous midwifery is national work and falls upon my entity, the Encoded for Story. I was invited to serve on a national committee where I helped advise the Secretary of the Department of Health and Human Services on improving maternal and infant health. And I was a part of I co-authored the very first report in 35 years of this committee's existence on American Indian Alaskan Native maternal. I'll put a link in the chat for you all. But you know, while many Native infants and mothers are still dying, we do have strength. And there are pockets of Indigenous birth workers and community organizations that are doing this really important work. And I'm honored to be working with a number of these organizations. And I will also drop links and names in the chat for anyone interested in following up. Thank you.
Hearing your voices tonight is just a wonderful reminder that, you know, the times when I was feeling very pessimistic and hopeless and, you know, will there ever be change? You know, I've been working at the New Jersey Department of Health and Senior Services that was completely ignoring midwifery practices. And I think California actually has been in the forefront previously as well in terms of supporting midwifery practices. But there's so much good news in even the first question for the panel. And so we may not get to all of the questions, but I think that even the first question is helping me to be energized about increasing access to midwifery care. So I thought maybe you could just talk a little bit about this idea of racial concordance that was addressed in the opening lecture. And, you know, it's somewhat, there's some debate around that. So, you know, does it really matter for, you know, how important it is for a Black woman to have a Black midwife, for example? But talk a little bit about the significance of racial concordance and why it does matter. And I think Kiki was getting ready to kick that off prior to my recognizing that I hadn't heard from all the panelists. But I now see all of you, so.
Actually, I am.
The ball rolling. Okay, Kiki.
I appreciate Janelle bringing up weathering because I think that's the value of racially concordant care. It's trying to undo the chronic stress that we're undergoing, Black and Indigenous women. There is no confusion for me, at least, why it's Black and Indigenous women. We experience the pressure of white supremacy most significantly, I believe, in this country. And it's navigating many different systems of oppression, not just the medical system, not just the obstetric system. You know, what if you are able to come into your prenatal visit and not have to worry about code switching at all? What if you and your prenatal provider are having the same conversation about the same music and the same food and using your same mama slang? And, you know, what if you get to be who you truly are while your pregnancy is getting celebrated? I think we're trying to undo this epidemic, you know, the maternal health crisis like moving forward for generations to come. This work that we're doing here, these conversations that we're having right now, is working to decrease the impact of stress on our bodies. And then I just want to share that how it's really showing up for me at this stage in my career and at this age that I'm really enjoying is I really want to see the midwifery profession grow, and I'd like to see more Black midwives. And it's the joy for me right now is seeing Black women, young Black women especially, in their prenatal visits asking me like, let me, you know, the thought of being a midwife never occurred to them until they're seeing themselves in me. And I didn't have a Black midwife, but I had that same moment of enlightenment. And so to be a part of that is really, I don't know, affirming. It's a big burst of gratitude for me.
I see a lot of nodding of heads, and kind of like the amen quarter is happening. Jhoanna, do you want to take the next stab at the question?
Sure. I mean, I think that cultural concordance care is trust. And like all of these things are achieved because we have the time, the space to really get to know. We have shared experiences. Like for me, sometimes it's a client that wants specifically an Asian Tagalog or Filipino Tagalog speaking. Sometimes my culture is being from LA. Sometimes my culture, it's all the intersections of just like, can I feel comfortable? My mistrust in the system is valid. Can I take that off and get care in your office? And also just like knowing, a very deep knowing that all of that weathering that Janelle and Kiki mentioned, like that we also have access to mental health support, like the things that are the greater support systems, because this is a long history and current practice of marginalization that impacts our communities. So I think it's the trust that we get to do as midwives.
Let me just ask a quick follow-up question. I can't imagine, like when I was pregnant, and if I had walked into a medical space and said, I want a Black midwife or I want a Black doctor, that would have been considered, we don't deal with race. We deal with, a good midwife, a midwife with experience. And so has that changed? And has that been, I mean, there's certainly reasons to document in terms of cultural competency, but how is that received in your setting and in your world where you are practicing? When a mother comes and says that they want someone who is like them in terms of their cultural background.
I think I just like, when I started, I recall that there were 2 Black midwives in the state of California, licensed midwives. I don't know about CNMs. And like, there just wasn't even access to finding a Black midwife like Kiki mentioned in their story. So while it's like, I understand how complicated that can be, the point is having options. Like whether that's like a necessity, it's like, do I have anyone in my community? Is there someone I can find trust in? Maybe not like a requirement, because I don't only serve Filipinos, but it's really like, do I feel comfortable? How do we find comfort and trust in our care providers so we can dismantle all of this and have a transformative experience, right? We can have transformative birth or we can have traumatic births. And it depends on your experience with your care team, the resources they bring. Yeah, so that would be my response.
I'm going to just ask at this point if Janelle or Jyesha have anything they want to add to what is said briefly, and so that we can move on to the next question in terms of time. Yes.
I can just briefly share, as I mentioned, Beloved Birth Black Centering is a bias for us group perinatal care program within Alameda Health System and our public health department in Oakland. And so we have an all Black care team, inviting Black folks to be cared for in that space that is very affirming and empowering and loving. And it was so clear the minute that we launched the program that people wanted this. We have had so much success with recruitment. Sometimes a group prenatal care or health systems just have a hard time getting folks into care. We haven't really had that problem. And it was so affirming from the beginning to see that we're on the right track. And I think that, it's a shame that we have been there's been so much of that narrative that you talked about, Linda, about like, well, it's wrong to want a provider of a certain race. That's racist. We should all just want somebody who's a good provider. But the reality is, as we all know, we're experiencing racism-based disparities. We're experiencing discrimination. We're experiencing weathering. We're experiencing all this inequality in our social structures that are impacting social determinants of health. And yet we're made to feel guilty. I think sometimes folks come with guilt about admitting that they do want a Black midwife if they're Black or somebody from the community. So I encounter that a lot. I actually often mothers will tell me as we're having the initial conversation about them enrolling in Beloved Birth Black Centering, they might say, I really do want a Black midwife. I don't sorry, I don't know if that's bad, and so it's been an interesting process, socializing this movement in our community of getting folks to a point of comfort of just naming the forces that are at play in our society and the value and importance of care that is really grounded in understanding who we are and being able to really respect and love on who we are. And so yeah, I think we're seeing more and more an embracing of folks being able to feel free to state their desires to receive care from folks in their community. And like Jhoanna said, community can be different things. In our case, we are inviting, Black racial concordance, but it can be on all different, layers of our intersectional identities, and even within each one, there's a lot of diversity. But I think the bottom line is that we all understand that it's a universal truth that care needs to be, community grounded, and folks need to be able to safely say what their preferences are. And I think mamas have spoken definitely loud and clear in our community and in other places.
And actually, there has been quite a bit of documentation in the past decade of improved outcomes when there is concordance in terms of the provider. I think there was a study that had to do with pediatrics, and they, so there's now, the objective, scientifically based information out there in very reputable journals that speak to the importance of that in terms of outcomes, measurable outcomes. Janelle?
Yeah, no, thank you. I will share two things. One is that for Native Indigenous people, oftentimes because our numbers are so low for historical federal policies that exterminated us and then actually committed policies that erased our identity, it's even difficult trying to just talk about concordant care, right? Culturally concordant, linguistically concordant. And so a lot of the discussion is about culturally safe care. It's about just trying to have a safe environment for people to birth in. And that's bringing in information to hospital systems and providers, talking about power differentials. And that's kind of where it is for some Native communities, especially rural Native communities in the North and in the Southern states. And we are getting closer to a point where we're able to talk about cultural and concordant care, and doulas are that route, because it's right now in many states, it's still accessible to become a doula while also having a job and a family, right? There may be a time in the future, well, that may change depending on what federal policies are placed or state mandates are put in place. But right now, it's a pretty accessible calling that people can take part in and be a part of someone's care. So we're talking about cultural safety in a number of instances. When I was serving in the National Advisory Committee, and Patricia Loffman, who's a certified nurse midwife from New York City, she was really bringing up concordant care. And I do remember that study that Dr. Hardiman published about the Black physicians taking care of infants had better outcomes. Mm-hmm. I also want to just explain that study too was because they were using common sense, because you're not going to apply racist stereotypes and rules, and a standard of practice that the Academy of Pediatrics had mandated was a necessary standard to save the white infant male and not the Black infant female. And then the physicians were like, that's stupid. Like, we're going to be common sense and we're going to apply it to everyone and all the babies are going to get this. So like, there was a bit of common sense going on in that, because it was a standardized protocol from the American Academy of Pediatrics that had this really horrific racist research that had this practice. But the concordant care I was turned off by it at first, and this is why. Because I have experiences working with BIPOC providers who, whether or not who were racial concordant, but they were providing the same type of care that was hurting people. Mm-hmm. And then I realized I'm not upset with the concordant care. I'm upset with the medicalized system. So I'm upset that, for all of the BIPOC families and communities out there where it is difficult to even become a doula, it's even more difficult to become a midwife or a nurse, and even more difficult to become a physician, that when they're in the process after having gone through their education and everything, that then they're in this indoctrination of medicalization of care, and they are applying that to everyone. And so it was the medicalized process that I was really resistant of, because I could see BIPOC providers enacting similar harm on people in the name of national standards, which is what Hardiman's paper was about, because it was about common sense, right? Mm-hmm. But if we have national recommendations for standards that do not account for different experiences or just common sense in general, a number of hospitals still call 1 minute of a cord not being cut at 1 minute as delayed cord clamping. Is that really delayed? Mm-hmm. Right? Like in a home birth setting, if you have a baby who really needs resuscitation, you probably keep the baby attached to the mom or to the birthing person. Yeah. Right? And because you're going to make sure that all of those resources are given to that baby. But in a hospital setting, 1 minute is sufficient and called a delayed cord clamping. Baby's gotten enough. Baby's gotten all it needs. That's not common sense. But that's an example about how a standard of care can be applied. And regardless of your background, you can then be indoctrinated and not see that it's harmful.
It comes to mind also, I don't go to the American College of Nurse Midwives conferences, but it's something to also think about in terms of nurse midwifery, and standards of care is being established there, and how much do they take into account cultural competency and the kinds of things that we're talking about here. Jhoanna, did you want to comment on the question? Okay, great. I don't know how we're doing on time, and we have 2 more questions to tackle. And so I think I might, there's no way that we have to talk a little bit about birthing justice, right? Because that's the whole purpose of this panel. And again, similar to culturally concordant care, so I think it's really important to think about what is birthing justice, because I think in some ways it's almost become a slogan right now of a movement, and I think it's a good slogan, but also to think about the fact I'm living in Virginia now, and I became aware of Booker T. Washington was talking about health equity and Negro Health Month, decades ago. We were talking about Minority Health Month decades ago. So what is it? How do we put teeth and meaning into birthing justice so that it doesn't become a slogan? My question. And maybe, Jhoanna, did you want to start with that one since we didn't hear from you on the previous one?
Oh, sure, I can start. There's many arms to birthing justice. I think birthing justice is just one addressing that we have race-based disparities, that we have disparities in our communities that need to be addressed, and having access to providers of choice for abortion, miscarriages, prenatal care, birth, postpartum. I think that when we talk about birth justice, it's addressing a problem that is unjust, that we as a society can contribute to fixing. And midwifery is one answer. Policies can support having access to midwifery. I think that birth justice is having providers that value culture and tradition as part of the healing and the care. It includes a team. It includes social work. It includes mental health, doulas, midwives, all of us. It includes many branches of care. And it's a way to build that trust that's broken. I think birth justice has an opportunity to address that there's a mistrust, that violence has happened, that people are dying and having poor outcomes and experiences, and say, like, let's look at that and let's build trust across in and out of hospital settings, and educate on options for all of these experiences.
Kiki's nodding her head. Kiki, did you want to comment on birthing justice?
I just think she
And
said it.
Yes, and in
Yeah,
terms of,
she said it. I think the only thing I would add is that the definition has evolved wonderfully. I think at first birth justice was making us aware that there is injustice in the birth care system, and that it's centered around, I think many folks experience injustice around the birth care system, but for people of color and Black women, it's centered around racism. And yeah, I mean, I just like what Jhoanna said. I think it's pulling in the reclaiming and remembering and bringing in the community around birthing. I think when we create justice for the birthing person, that's radiating out and creating justice in the community, shifting our ideas around what birth should look like, feel like, be like. Yeah, I think it's more than just the birthing person. It's all of us and how we're impacted by birth stories.
I was just thinking that I think sometimes it just becomes like a handy slogan for people running for office, but that don't have put the meat on the bone that you are putting on the bone in this conversation. Janelle, did you want to add anything to what's been said?
I would like to share that in the Indigenous area that there is a term for Indigenous birth justice, and it includes like a connection to land, like having that as a part of a named and identified portion of our experience, and access to traditional foods and plant medicines. The Alaska Native Birth Workers community, doulas in Alaska, they have a slogan where it's sovereignty from first breath. Like we're all free from, first breath. That's amazing. Along with integration of cultural practices. So, and I think of, birth justice, definitely I'm thinking of also like it's been expanded in the Indigenous area to include these important things that just are a reflection of our histories of like what has been taken and what we have been missing and what we are still trying to reclaim.
Thank you for that. Jyesha, I saw you nodding your head, so
yes,
kind of
all of that.
With the amen, so I didn't know whether you wanted to add anything.
No, I think all of that was wonderful. I would just add, I think a lot about, how much of a radical shift the United States needs to make in order to actually be walking the walk with birth justice. and just like, you know, the very weird space we live in now, where I feel like there are a lot of, like you said, there are politicians, there are policymakers, there's a lot of folks in areas of power and influence who are stating that they really want to be doing the right things by, you know, mothers and birthing people and families, and want to be, you know, investing in perinatal care. But yet we have so little implementation of the evidence-based strategies. So it's very weird. It's a very weird, like, cognitive dissonance thing that I just is hard to grapple with when we actually know what works. So this isn't a mystery. It's not rocket science. It doesn't require some like big investment from some fancy new pharmaceutical firm. Like, it's not that. We know that. And we've known that for like ever. And yet we continue to have these preventable you know, high rates of morbidity and mortality impacting our marginalized communities. And, you know, as you were saying, Kiki, everybody, nobody's doing great in America with perinatal care is the truth. And so when you look at, you know, us being 50 to 60th in the world in measures around maternal mortality, infant mortality, we know that, you know, we've over medicalized, we've, you know, have so much inequity, we have so much, you know, built into our structure of perinatal care that is not taking care of folks. And we know if we implemented midwifery at scale, if we implemented, you know, racial cultural concordance, wraparound social support, and high quality education so folks can be able to navigate the experience, and doula care, if we did, and group care, if we did all of those things together, we really wouldn't have the same level of these preventable disparities. So it really feels like we live in a country that has, you know, in a big way, you know, accepted this as just, you know, inevitable that we're going to have, you know, moms and babies and birthing folks suffering. And so that, I think, is the point now. There's so much activism to be done just around getting people to commit the resources, the investments needed to really just do the things we know work. And you know, we have the answers in our community. So that's the great news.
I am so glad this panel is being recorded, because there's so many places and so many people who are not on this webinar today who need to hear these voices. Because, you know, a lot of times when you say birthing justice, the response is, well, if everybody had a doula, then we would have birthing justice kind of idea. So the complexity of it, and understanding multiple strategies, and also understanding where we are as a nation, not only in Black communities, Indigenous communities, Latino communities, Asian communities, but where we are as a nation in terms of the world, in terms of our outcomes. And that's the, you know, the seeing the big picture, I think, has been very, very valuable in the comments made today. So this brings us to our final question.
Sorry, can I just add really quick?
Kiki, go right ahead.
I really think it's important that we explicitly say that birth justice is midwifery care. It's common sense care, as Janelle said. It's not something, we didn't have to study normal physiologic birth to prove that it was evidence-based. We just centered human connection, and we provided the care that we wanted for ourselves. And that's birth justice, you know, like you said, while doula care is extremely important, and reducing obstetric violence and eliminating obstetric violence is absolutely necessary, midwifery care and birth justice are really synonymous for me.
So important, because it's been so complicated so that it seems that it's not doable, right? And then if you say, this is the definition, then it becomes very clear what the strategy is, as opposed to, and it's measurable. That's the other thing, measurable outcomes, right? We know about the quality of midwifery care. So yeah. All right. So the last, well, I think that's a good lead-in for the final question, which is about the future, right? Of what the vision is. But I think what I like about this question is that we've been, you know, doing big picture, you know, the nation, the world, but this question is to bring the question home to California. And so what is your sense of a grand vision for the grand midwives here and the grand midwives in California in terms of turning around, you know, the problem with the outcomes and the quality of care that we've been discussing? So I don't know who would like to begin that. Maybe Jhoanna, do you want to speak to that? The future?
Sure. I have lots of grand views. I think that The future is access, is making sure that people have access to their choice providers, for sure. That I dream of a healthcare system that truly values midwives as leaders in improving maternal health outcomes, not just marginalized providers, and that we have a better dialogue from out of hospital and in hospital providers. I think that there would be great improvements if we had smoother transitions. And while we are increasing schools, and thankfully there are not 2 Black midwives in this state, and there is a diverse midwives and so many more coming, I really hope that people fund opportunities for them to work where they choose, whether it's in hospital or out of hospital, that the value of this education can be applied in many places to support families. So I think a lot about the future of midwifery, and everyone who's eager to do this, and like, let's make sure they have a place to share this skill and to prevent unnecessary complications in our communities. I had more, but I'm gonna stop there because we have very.
I know I didn't hear that last comment. I think Kiki, were you going to add something there?
Yeah, unless you were going to repeat your last comment. The future is more midwives. The future is more midwives of color, more Black midwives. I'm passionate about that. The future is more birth options. I'd like to see more out of hospital birth options. Passionate about a birth center being in the city of Oakland. And I'm passionate about seeing birth centers all over every state. And then the future is hospital-based providers getting some training in out-of-hospital care, because normalizing birth for everyone who is a birth professional or expert will help improve outcomes in the hospital setting. And we're always nervous about saying that, but it's pretty basic. People love their home birth experiences. They love their birth center experiences. They're really pleased with their outcomes. Let's require that every obstetric provider engage in that kind of joy, and bring it back to their place of primary practice. Yeah,
thank you. I'm pretty sure I'm not getting messages about time, but I'm thinking that probably our time is winding up for the panel. And I want to thank all of you. And as I was thinking about what I wanted to say in the closing, is that I'm really thinking about Margaret Charles Smith, and I'm thinking about our Indigenous midwives, our Asian Indigenous, our Indigenous midwives who've been on the land here without recognition, our midwives of all cultural backgrounds who are now ancestors, are very much with us and are celebrating the fact that as we are kind of adopting that Sankofa idea of of looking back and using the energy of the traditions and the success stories and the groundedness of midwifery ancestors who are with us now, and their spirits are living in the work of Kiki and Janelle and Jyesha, and I hope I'm pronouncing all the names correctly, Jhoanna, and that those tradition and that culture and that spirit is alive and well in each of you and in the many, 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 many midwives who are following in the tradition of those ancestral midwives. So thank you very, very much.
Thank you so much, Linda, for your incredible facilitation skills, and thank you to all the panelists here. We are going to have just a little bit of time for a Q&A. I know there's one question in the Q&A box, but before we go ahead to that, I just wanted to make sure I give just a chance for any of the panelists to briefly talk about in what ways policymakers or advocates that might be on this call might be able to support you and your practice, or also that grand vision that some of you were able to speak about.
So I will just share that, policy-wise, we have a number of momnibus bills that are trying to go through, right? So making sure people are aware and are voting, and our policymakers are able to do that. The other part of that is that the CDC had a campaign called the Hear Her campaign, and it was to educate healthcare providers just to listen to people who are pregnant, right? To listen to them if they had symptoms that could be turning into preeclampsia, depression, or a hemorrhage. But I would like to take it a step further, and this is a big ask for our nation. We're so far away in our nation from health literacy or just understanding normal health, let alone like women's health or childbearing health. But it should not be on her shoulders or that person's shoulders, right? For being pregnant, for having a pregnancy, for going through childbirth or postpartum. It's a shared responsibility for our nation. That means that the people who are involved in helping create a life are also important in understanding the person who's carrying that life forward. So we need nationwide policies that educate children on some of these basic issues. So like when a pregnant person goes to a gas station and all of a sudden they don't look so well, and the person who's pumping gas next to them can ask, because they have knowledge about pregnant people should not look like they're going to faint, can ask, are you okay? Can I help you? Rather than in our country, it's very siloed in parts of our country where you don't look at your neighbor, you don't look at people in the eye, you turn the other way, you don't help. And this is just trying to help people see one another in community with one another for our nation to have better health outcomes. So one, seeing each other in community with one another, anything that will encourage that and nourish that. And two, the health education and literacy. It's not on her shoulders. It's not her burden for health outcomes. It's on our shared shoulders. It's a shared burden for all of us.
Anyone else before we move to the Q&A?
I can really quickly mention something on policy. We are really excited at Beloved Birth to be partnering with Centering Healthcare Institute and other strategic partners in the coming years to advocate for enhanced reimbursement for centering pregnancy group care. The interesting thing that's going on is, in California, we have actually the most centering pregnancy group care sites going on, more than any other state. So we have a lot of clinics and hospitals who are providing this wonderful evidence-based group care model that's been proven to reduce things like preterm birth and low birth weight. So it really helps us to be able to carry our babies full term, birth them at healthy weights. So what do we know? It's reducing stress. It's addressing the weathering that's happening. It's a community-centered way to get care. It's got a lot of other great, benefits as well. But here in California, we don't have a reimbursement structure to actually pay for that through insurance. So this comes to one of the justice issues. It should be a person's right to be able to have access to group care. Why? Because it's shown to have better health outcomes and a better experience. But most people don't. But here in California, we're actually ahead of the curve in the number of sites, but we just don't have the reimbursement in place yet. Whereas there are 10 other states in the country that do have enhanced reimbursement for centering care. So that really encourages clinics and health systems to switch to this evidence-based practice, because it does cost money to switch. It's hard to convince, health systems and clinics that are already strapped, to invest to do, care a completely different way. But that's what's needed. We have to do care a completely different way, or else we're not going to improve outcomes. So, group care is a midwifery. It was created by midwifery. It's a midwifery model of care, and that's what's needed. And so we're really excited to be able to be pushing for that here in California. So I welcome, anybody who's interested in that, get in touch with us. We're going to be trying to make that change in the coming years, along with lots of other things we'll be up to. So just want to mention that.
Awesome. Thank you so much, Janelle and Jyesha. Apologies, I'm losing my voice. Janelle and Jyesha for that contribution. I know I promised we would ask that question, but I'm just looking at the clock. For that person that asked the question in the box, please feel free to reach out to Midwifery Access California. We can get you an answer to that question. I actually want to kick it off to Liz or Holly to talk a little bit more about some of the policy opportunities that are happening in California, and then for an announcement from Asaya right after that. So Liz and or Holly, please feel free to jump in.
Thank you so much. I just want to give a big thank you to all of our panelists and all the work that went into this, and Linda for your wonderful facilitation. So thank you, Linda and Candace and Lauren and Kiki and Jyesha and Jhoanna and Isaiah and Janelle. Just really, I think this is our best webinar yet, and probably will be for a long time. You all really just articulated exactly what midwifery care is, and how culturally concordant midwifery care improves outcomes in a way that would otherwise not be able to be articulated by a singular person. So this is just wonderful. In terms of policy priorities in Midwifery Access California, knowing that we're short on time, I just want to say what's great about this coalition is our ability to be in our separate spaces and our separate organizations working towards the common goal of advancing access to midwives. And that comes in many different forms. Sometimes it's payment reform, as Jyesha was just talking about. Sometimes it's the legislative side. Sometimes it's the push towards education and training programs and so forth. So on that note, I'm going to simply pass it to Isaiah to give us this announcement.
Thank you, Holly. And Candace, if you can pull up our slides, we've got just one final, very exciting slide to share with you all. And that is that I have the pleasure of announcing that Common Sense Childbirth School of Midwifery will be opening a California satellite school. For those of you who don't know, but most people do, Common Sense is the only, I'm going to emphasize, only Black-founded Midwifery Education Accreditation Council, or MACa, accredited direct entry midwifery school in the United States. Y'all know Jenny Joseph. That's her beautiful photo right there. And I will just read really quickly the mission of the school, and that is that the mission of Common Sense Childbirth School of Midwifery is to provide quality, practical, and culturally sensitive midwifery training and education that will prepare midwives of caliber who can represent themselves and their profession in any arena. They aim to inspire students to become perinatal leaders in the maternal and child health field, willing to provide access to respectful maternity care for all communities, with an emphasis on eliminating health disparities through the education and empowerment of women and families so that they can once again safely experience their birth their way in a common sense way, as Jenny Joseph has mentioned, and as Janelle and others have mentioned today. And so I'm very thrilled to be able to announce that. Stay tuned for more information on the upcoming school. Be sure to follow Common Sense Childbirth School of Midwifery on all platforms. And of course, as dates and info sessions are announced, we will be sure to share out with you all. So that is the exciting announcement that I have, and I will kick it back to Candace to end our day today.
Amazing. Thank you, everyone who was able to stay on a little bit longer for that announcement. I know we promised it would be worth it, and I think it is. And thank you again to all of our panelists, our facilitators. At that, we're going to close this webinar. And I hope everyone, especially those here in Southern California, are staying safe. And I wish the same to everyone, of course, too. Times are wild. So yeah, glad to have been in community with all of you. So thank you, and please stay tuned for the next webinar coming up from Midwifery Access California, and you can check that out.